and this is being recorded. It does take me just a little bit to get it back onto our website after the after I get it through comms. So be aware of that. If you have to leave early or something like that, you can always find these recordings, especially if you need to reference it later, which we're going to talk about the SACA today. So we will go ahead and get started here. And if you've heard or been around at all, you've heard the term SACA. And what does that exactly mean? Well, the SACA stands for the Self-Assessment Categorization Application. And today we're going to focus on the SACA for the level 3s and level 4s, the state verified level 3s and the level 4s. We're going to talk about how to answer the questions on the SACA, and we're going to give some specific examples. We're going to walk through each page and to make sure that everyone is on the same page. As I see these SACAs in the supporting documentation come in for verifications, I see a lot of variability. I would ask somebody, please mute yourself. Oh, we got a call. Michelle, it looks like it's coming through. Let me see if I can mute you. There we go. Okay. We're going to talk about how the SACA in relation to the Trauma Services Summary Report as well. So we're going to just kind of hit it from all ends here. And sending emails to a few people still trying to get in. Okay. Let's see. That's what we're going to talk about today. So kind of understanding the SACA, the supporting documents, the timeline of events, what does all of this mean is what we're first going to kind of cover today. And why the SACA? Why is this even a thing? Well, Chapter 147 of the Iowa Statute and Administrative Rules govern our entire trauma system. If you've heard Jill Wheeler or myself talk about the legislative rules or administrative code or any of that verbiage, in there is what talks about why Iowa is an inclusive trauma system. It talks about how we verify each one of those, what level means what. It also has the adoption of the resources for optimal care of the injured patient is actually noted in law there. So that's where you can find those in Chapter 147A. And I just took out a snippet of the specific part that talks about the SACA. Categorization as a trauma care facility shall be determined by the department. The department is HHS, Health and Human Services, Bureau of Emergency Medical and Trauma Services. And that is by the department from the self-reported information provided to the department by a hospital or an emergency care facility through the self-assessment categorization application provided by the department. So that says to be categorized and verified, you've got to apply or submit the SACA to the department, which is me, and then that is the reason for this whole verification process every 3 years that we go through. Okay, as of today, and this is important, especially if you are a level 3 and you're on the call, and I'm kind of just scanning people, and we do definitely have some level 3s on here. So legislation has been awfully busy in the springtime. And as of today, the remainder of the 2025 level 3 and level 4 verifications are going to be verified on the Orange Book, which is the Resources for Optimal Care 2014 edition. Our legislative rulemaking moratorium is coming to a close. Finally, our rulemaking has been on hold since I started, so I don't really know how this is all going to look like, but we're going to have some new rules that are scheduled to release April 1st, 2025. And we anticipate that the gray book adoption is going to be in these rules, and that is the gray book adoption for level threes. We don't have a gray book, or I say gray book, but you know that it's the Resources for Optimal Care 2022 version versus the 2014 version. We don't have level four gray book rules. When the college released the gray book in 2022, they left out level four trauma care facilities. That is very much going to be changed. The ACS COT has been working on level four gray book rules for quite a while, and we expect that to come. We don't know when. However, in the meantime, our legislative rule, we wanted to adopt the gray book for our level three trauma care facilities here in the state, and that appears to be, and I say appears to be because things can change, to be happening April 1st of this year. Of course, we're going to allow the grace period. So that's why I say that level threes will be verified on the Orange Book rules for the remainder of 2025. So nobody panic if you are a level three trauma care facility. And the reason why I also say do not panic is that going over the gray book, if you've looked at the gray book in any kind of form, again, the 2022 standards are the gray book. And that can be found on the ACS website, and you can download that. And I think there's been only one revision to those standards. Again, if you're level one and level two on the call today, you already know about the gray book because you are verified by the college. College obviously follows the gray book standards in 2022, the 2022 standards. So level threes, take a look at those gray book standards. There is nothing completely earth-shattering. I know Craig and I have had this conversation before that you aren't already doing as a level three facility. Those Orange Book rules are very similar to the Gray Book rules. They are not identical. So take some time, look through the Gray Book if you are a level three and you are expiring 2026 and beyond, because I don't have a timeline on when we would mandate that, but it would be probably 2026 or level threes to be on the gray book. If there are some crazy standards in the gray book as a level three trauma care facility that you are not currently meeting and it wasn't a rule for some reason in the Orange Book, reach out to me and Jill and I will meet with you individually. So we look like this rule-making moratorium is finally coming to a close, and we're expecting to see that gray book adoption for our level threes coming in April, which is kind of exciting. Okay, questions on that? Okay, we're gonna keep moving because we're talking about Orange Book, SACAs, and how we do it. Again, level fours, Orange Book, Orange Book, Orange Book. Just to be very clear. Okay, so when we're trying to figure out when am I going to expire, when do I have to have this paperwork in, what is happening, I don't get it. So I've kind of set up an example here to talk about what you can expect when. And of course, everybody's verification expiration date is different. So make sure you know when that is. And we're just kind of gonna walk through this example. Of course, there's still some exceptions from this rule. COVID, global pandemics tend to throw everybody off of their 3-year recycle, or cycle, the 3-year cycle. And so I do have still some sites out there that will be coming close to their 4-year things, but we don't have any proclamations as today. So you should be on a 3-year rotation. One thing to note here is that the SACA application that we're going to talk about that looks like this. Let's see if I can jump ahead just quick for a minute. This is the SACA. You'll see up here in the corner, it'll say level 4, and it is almost identical for level threes. Not quite identical, but almost. So this is what your SACA is actually going to look like. And this is the application. At the end of the SACA is a laundry list of supporting documents. So you'll hear me say SACA, and sometimes that's just being all-inclusive of your application and your supporting documents. But again, the supporting documents that you need to turn in are going to be on a laundry list. The back of the SACA, and we'll go over that because we're going page by page of the SACA today in case there's any questions. Okay, so what can you expect? Say that you are expiring August 1st of this year. And it's really kind of a counting backwards type of thing, what you would expect. So on February 1st, this already happened for our August 1st facilities. On February 1st, you got an email, the trauma program managers, trauma coordinators, whoever we have listed as the point person for your trauma program, got an email from me that said you're going to expire in 6 months. And attached to that email was your SACA application that I just showed you. It is a blank fillable PDF format. And you also got the checklist. Now, the level 3 checklist, again, in 2025 from the Orange Book. And for our level 4s, the checklist exactly derived from the Orange Book as well. That's where these checklists come from. That is the exact list that the survey team uses to see if you have met verification. The level 3s and level 4 checklists are completely different. The SACAs are similar, but the checklists are different because there's more standards for the level 3 to meet, more criteria for them to meet. In 2 months, you'll need to get that SACA filled out and have your laundry list, aka your supporting documents, back to me. So you get your notification on February 1st, knowing that you expire August 1st. On April 1st, you need to turn in your SACA and supporting documents. I try to be fast in saying I can open all of your files, and I will return an email to you confirming that and including next steps. Of course, tomorrow, March 1st, there will be multiple emails and multiple files coming in from the people that are would be expiring 4 months from now, April, May, June, July, that would be expiring July 1st. So there will be SACAs coming in to me. So I try to get those emails, the confirmation emails back to you as quick as I can, but I do get a little bit behind because I am opening those files and organizing them and make sure that I've received your SACA. The next steps are included on there, the communication that you will either be doing in on-site/virtual. And I say that because if you want to do on-site, I do the best that I can to honor that and get the survey team on-site. Sometimes schedules don't work, and sometimes we have to go virtual versus the paper review. And the paper review is only open to the level 4s. And if you choose a paper review and you've submitted your SACA on time, you are essentially done. And then it's in my court where I'm reviewing your documents and also contracting another nurse surveyor to look over your documents and develop a final report for you. In that time, if you have chosen a paper, I will be reaching out, requesting additional documentation if need be. If I have any questions based on your paper documentation for your paper review, I'll be reaching out to get clarification for that, just to make sure that I get the final report accurate based on what you've submitted and what you're doing in your trauma program. From April 1st to August 1st, there's that 4-month window between the time that you expire and the time that you turned in your SACA. What is happening then? At that time, I'm reaching out to physicians, surgeons, and nurses for the on-site and virtual visits. I'm arranging their contracts, their schedules. I'm tying it into my schedule, and then I'm reaching out to the sites and collaborating with their schedules and trying to make that all happen. I would ask for some grace from all of you when we are making this. I appreciate anybody's flexibility as well when we're doing this. Remembering if you take the 100 and whatever 14 hospitals that I'm verifying on a 3-year cycle, there's anywhere from 2 to 6 hospitals each month. So I do appreciate some grace when I'm trying to get these scheduled. So that's what's happening in that 4-month time period. We settle on a date. We start to get some things settled. Also, I should say when I did your confirmation email that I could get your SACA opened and all your files, I do send a sample schedule with that email. Obviously, you'll need 4 months to kind of figure out schedules as well. On that sample schedule tells you exactly who should be participating in your site visit. Also, there's a chart review template that comes with that email as well that I've now opened your SACA, and that talks about chart preparation. So if we're coming on site or virtual review, you're going to need to have some charts organized and put together. Preferably in a PowerPoint, and chart review is part of that PIPS session that is listed on your schedule. We're not going to get too far into that today. I just wanted to make mention to that. Okay, so let's keep moving here. SACA facts. So the very first thing that you should do when you get your blank fillable PDF from me saying you expire in 6 months and your SACA is due in 2 months, the very first thing you need to do is look at your review period. Your review period is going to be, think of it as a 12-month snapshot that you are submitting to me and the surveyors that are going to give the picture of your trauma program, not just this year or last year or next year, but your continuous trauma program that you have at your site. So that 12-month snapshot just essentially kind of focuses in on what happens in a typical year in the trauma program at your facility. So you'll see this little piece here I've taken right out of the SACA, and it says answer the following questions based on your 12-month period of your choosing. This will be the same date range utilized when running your image trend trauma services summary report, and that's attached to your SACA and supporting documents. So this 12-month period to your choosing, that's where people really struggle with, well, what does that mean? When am I supposed to have my review period? What does recent mean? So we're going to kind of take a look at that example again, just so we can try to figure out what my review period should be. I've now got my blank SACA in front of me, and what do I do next? So I expire August 2025. My review period would make sense to be January 1st, 2024 through December 31st, 2024. So you want to make sure that you're kind of counting backwards to making sure that you're going to have what you need to have on the SACA. In that registry section of the SACA, the excerpt I just showed you, it will ask you all sorts of numbers about your trauma registry. And the reason why I want you to kind of count backwards is because you need to make sure that those numbers that are on the SACA that are coming out of your image trend registry match. And those numbers need to be, those cases for your review period need to be into the registry, they need to be done, and they need to be complete. Well, as you all know, that you have 60 days past the time of discharge to get your image trend patients into the registry. So if I make December 31st the end of my review period, I really actually have till March 1st to get those December 31st patients in. So let's see, I expire August 1st. I put my records in. I have till March 1st, but I only have till April 1st to get my SACA and supporting documents in. Maybe I want to back up my review period a little bit more to give me a little more breathing room, which is totally fine. So again, it's your choosing on what review period that you want to do. Perhaps you want to go from December 1st, 2023 to November 30th, 2024. That allows you an extra month. It does not have to be a calendar year for your review period. It does not have to be a fiscal year for your review period. It is just truly a review period that you pick, must be recent, and also allows you plenty of time to have those end of your review period patients into the registry. Now, if you're concurrent with your registry, you don't have to worry about it. This calendar year 2024 totally makes sense for the timeline example that we have up here. 12 months of data needs to be 12 months of data, and think of that 12 months again, snapshot when you're filling out your SACA. And why I say that is that 12 months are what you're submitting your trauma committee minutes in. It should be the same 12 months that you're running your image trend trauma services report in. If there's been PI issues identified, it should be that same 12 months. So your review period is really that snapshot in time, and everything should fall in that 12 months. Now, if you are a small level 4 and you don't have a whole lot going on in that 12 months, of course, you can expand that window to maybe 18 months. We see this a lot with pediatric review centers that you have to expand because there's just not that many pediatric patients. So reach out to me if you need to say, look, we just didn't have any PI issues, or we had minimal meetings. I want to make my review period. Does this make sense? And then I can help you walk through this example and make sure that you have that review period set. Not to be too picky, but January 1 to 2024 to January 31st, 2025 is not 12 months, that's 13 months. So really make sure that you're getting 12 months, because on the back end, I'm running reports and making sure that your numbers are matching. So questions on that? The last thing that I would say about making sure that it's recent, say I picked a calendar year of 2023 for this example I have on the screen. Does that make sense that we come in August of 2025 to review something that happened in 2023? Of course not. Again, this is a snapshot of what your processes are. We want to see it in real time, but PI happens all the time. So we really, and it's a moving, alive animal, your trauma program. So you really want to get a great snapshot of what is currently happening. Now, what I will pose to the group is this first question. So I've had many sites reach out and say, I don't get what my review period is. I didn't understand that my SACA should be my 12 months of my trauma services summary report. And a lot of times when we come to the visit, or if I'm looking at your paper review and those numbers don't match, that's usually the first thing that I'm going to say is, hey, what is this time span here? So we can kind of narrow down on what's happening. Would it be helpful for you, the sites, if I already assigned your review period to you when I send you the PDF blank fillable form? That would be a question that I would have for you. Feel free to put your answers in the chat. I think that's enabled. Because I would love to hear if, you know what, I don't even want to think about it. When you send me the blank SACA, just tell me what the review period is that you want me to look at. I would be happy to do that. And again, you can also reach out to me because I've kind of thought around this, because it's good and bad. You may have had some disastrous cases that really had some great PI during a review period I happened to pick for you, but also having the power in your control also lets you say, hey, we reviewed this period because we had a huge volume for some reason. So think about that and let me know if that would be helpful for you. Okay, other SACA facts. It must be turned in, or it may be turned in early prior to that. In our example here, April 1st date, or whatever it is, 2 months. If you have been working on your SACA, it may be turned in early prior to the due date of the SACA. However, that doesn't guarantee you an early visit. Again, I've got a pretty scheduled distribution of all the hospitals, so it's really hard to kind of maneuver sites around without maneuvering somebody else. If you do decide to turn it in early, it must be complete, meaning the numbers have to make sense. Your registry needs to be complete. It can't be, hey, we just took this to trauma committee 2 months after I submitted my SACA. I just wanted you to have this. Well, it really just needs to be complete. I will lose track of policy here, from this hospital here to this hospital here. Please add this to my SACA. Please add this to my SACA in that 4-month time frame. So try to make it as complete as possible. Organization is so much appreciated. PDF files bookmarked, clearly identified in files. is just really, really helpful. When we, what you may or may not realize when you zip upon zip upon zip, which you have to do to get it through email, and I completely understand that, the pathways get too long. And by the time we get to the file, many times from my end or the surveyor's end, we can't open it because the file path is too long. And then we can't get them unzipped. And it's really difficult. And I will take ownership of that on behalf of the state, because we want a secure uploadable platform for all of you just to put files in. We do not have that yet. So we are still stuck in the days of emailing large files. Just organize them the best that you can, and make sure you're letting me know how many emails I can expect to you when you're submitting your SACAs and your supporting documents. Also, make sure that that application is signed and dated. That helps me understand when the SACA was in case I haven't looked at it recently. Okay, let's see here. I get to talking and forget where I'm at. Okay, how do I answer the questions? The SACA tag. I really am got a dry sense of humor when I was making this PowerPoint presentation, apparently. So again, here's your first page of your SACA. I happen to pull up the level 4, looks the same for the level 3. Very self-explanatory on this page. The name of your facility. We want the official name of your facility that's listed on the IHA website, just to be consistent and professional on our final reports. And a lot of hospitals change names and we don't realize it. So please make sure that you have your most recent name, and make sure that this is all accurate. Address, of course, and make sure that your emails of all of these people are very accurate as well. I know emails change from the time that you submitted the SACA to the time that we get there, and that is just kind of the nature of the beast, but try to make this as accurate as possible. Registrar here, when we're talking about FTE dedicated to the registry or the trauma registrar, we want to make sure that these are how many hours are spent on the registry. And a registrar is going to be anybody that's doing any abstraction with the trauma charts. And I get a lot of questions about trauma support staff here, injury prevention, quality, EMS. This is anyone that helps with your trauma program. So this may be your injury prevention people in the hospital that you rarely talk to, but they're always working with falls. This could be your quality department that helps you lay out some metrics in your hospital. This is your EMS liaison that comes. There might be somebody else that comes to your trauma committee. And this is just really anybody that helps at all or touches any injured patients that come through your doors and how they support your trauma program. So there could be a lot more people there than you think. Number of beds in the facility, very easy stuff to get a hold of, and whether you have telehealth and what do you use it for. Basically, we're just after, are you pushing the easy button for trauma patients and utilizing telehealth with that? The next page of the SACA, also pretty self-explanatory, number of beds, who your ED medical director is, your nurses on the roster, how many of them have TNCC or ATCN, your other required education, and the ED provider coverage. So even if this is out of house, if we have 24/7 on call, if we use an APP from 2300 to 07, just really a nice description of how your emergency department is covered. ED provider response times less than 30 minutes. For your trauma activations and what percentage of the time. That is a criteria that 80% of the time they must be there within 30 minutes. And everyone does a great job of listing this out. Just be ready to, in case we have some questions on that, be ready to show us or tell us how you got that information. And that's whether it's a paper chart or an on-site visit, because we may want to see a little bit of proof or documentation. And then this section here for the drop downs, under board certification, we get lots of questions about this all the time. Do I have to have current ATLS for the providers? Let me first say that if as part of your supporting documents, you have to submit 3 months of ED schedules. And the reason why you're doing that is to show that you have had coverage into your emergency department 24/7, whether that's out of house, in-house, APPs, whatever. But when I look at those schedules, I will be comparing that to this list on your SACA. And if I see a bunch of names, which may be a locum that happens to be one shift out of the 3 ED schedules that you submitted, that person better be on this list, because we don't want people who are in your emergency department taking care of your injured patients that don't have ATLS. So, and that will obviously raise a red flag if I see physicians that aren't listed on your SACA that are in your ED schedule. So make sure that those match up. List all your ED providers and list their board certification. So the questions that we get at what if I don't have ATLS, and who is the exception to having current ATLS? Current ATLS is taking the class every 4 years and having a card to document that. So that's what I talk about with current ATLS. The exceptions to that are EM boarded physicians. If you are an EM boarded physician, a few years ago, they made the decision that you are grandfathered in, and when you are up for reboarding or recertification of your board, your trauma education is in there. And so the college and us decided that was good enough. Recognize if you are an EM boarded physician, you are getting lots of ATLS and ATLS education. So those are the exception. They have to have had ATLS at least once. And how do you prove that? If they took it in 1988 and your ED physician is still there and they have no idea where their ATLS card is, just make them sign an attestation that says, yep, I had ATLS, and I will accept that as documentation to their ATLS concurrency. Same with surgeons. Again, not required in level 4 facilities, but if your surgeon has had ATLS at least once. If they are the surgeons that are responding to your trauma patients. So again, that's why I say not required in level 4s, but level 3s. If you do have your surgeon response, they must have had ATLS at least once. Everybody else has to be current in ATLS. So these are your docs that are boarded in family practice. I am internal medicine, not boarded at all. They need to be current. Again, presenting that ATLS card, having that submitted in your supporting documents. If you're a PA, if you're a nurse practitioner, those mid-level providers or APPs, advanced practice providers, or APCs, advanced practice clinicians, whatever you call them, they need to be current in ATLS every 4 years. So I hope that that really clears it up. We get questions about that all the time. People ask also, what about my trauma medical director? Did they have to be current in ATLS? Well, if they're EM boarded, no, because again, they're grandfathered into being current in ATLS. Many sites do put current ATLS in their job descriptions of their trauma medical directors. And the reasoning for that is that the trauma medical directors are doing the second level of review on these trauma charts. So they should be most up to date with the most current ATLS guidelines. So we know that patients are getting cared for appropriately. We do expect that to be coming as a requirement for level 4 TMDs, that they will have ATLS. I'm not sure if it's going to be the exception with the EM boarded to be determined yet, but know that the reason why I say this, there are situations in the state where one, they're the trauma medical director, 2, they are not taking care of patients in the emergency department, and 3, they are boarded in family practice. We have had that happen, whereas like, well, I don't even take care of patients anymore. Why do I need ATLS, even though I'm boarded in family practice? My question back would be, why are you the trauma medical director? You are the person that's reviewing these trauma charts, doing peer review on your other providers. Wouldn't it make sense that you are most up to date on the most recent ATLS guidelines to make sure care is appropriate? So some changes with ATLS might be coming in the gray book for level 4s down the road, but That's who needs ATLS. Again, if you have questions, be sure to reach out, but fill this out completely. Okay, so yeah, that's what I wanted to say about that page. The next page of the SACA is, again, really self-explanatory. Your EMS providers that are coming in here, your level of service and their medical directors. This would be your catchment area of your hospital. Anybody that is any EMS service that's bringing patients to your hospitals, to your emergency departments, what level of service they are, paramedic, conditional paramedic, ALS, BLS, transport only, and who their medical director is. And in chapter 3, this really helps meet a lot of those criteria about chapter 3, because that helps show that collaboration between pre-hospital. If the medical director for your EMS agency is the same as for the hospital, which many times they are, that really shows that collaboration and making sure the protocols are followed back and forth as far as case review. So make sure to have this filled out in its entirety too. Some really basic questions. What level 1 and level 2 care facilities do you transfer to? This is actually the snapshot from the level 3 SACA, because the level 3s transfer to the 1s and 2s. This question is worded to which higher level trauma centers for a level 4 SACA, because a level 4 may transfer to a level 3. Surgical services, again, required for the level 3s, not for the level 4s. So fill this out in its entirety, what they are certified in and when their ATLS expiration is. And level 3s have to have those general surgeons. And you'll hear me say general surgeons and trauma surgeons, that verbiage interchangeably when we're talking about level 3 hospitals. So trauma surgeon, general surgeon is the same thing when we're talking about this SACA. And then here on this far column, what their percentages of trauma committee meeting attendance. Explaining the coverage, how it works, and what the expectation is when they respond to your trauma alerts. And then their response times. And again, same thing with ED provider. We will need to see some proof that they are responding within 30 minutes to the trauma activation when your trauma surgeon is listed as you will respond in your trauma alert policy. OR availability, that last question down there at the bottom, that will, it's just a description of when it's available, who comes in, how does PACU get notified? Do we know what their response times are? Who's tracking that? Do we know if the patient's going to PACU or ICU at your level 3 facility? So just really kind of a nice little summary of how it all works for your facility. The next page here, this is the picture of the level 4 SACA. So this is, again, pretty self-explanatory. If you do not have these services, write NA. You do not have to have ortho. You do not have to have an ICU. You do not have to have continuous anesthesia response as a level 4 facility. You can list your liaisons, for instance, even though ortho isn't required. I've seen a name filled in here because we have, say, outpatient surgery availability Monday through Friday, 7 to 3, and perhaps we've admitted a trauma patient that was sick enough to get into the registry, but we're going to fix them at our facility on Tuesday per the ortho surgeon. If there's any issues with that, then you need to have an ortho liaison listed there, because that person should be your go-to person if you have any involvement with the trauma patient. So when you're writing NA, write NA if you don't have those services. And if they are actively involved in caring for the trauma patients at your facility, need to have that filled out. And then if they're not on call 24/7 as a level 4, we don't have to have that. That's okay to explain that in that box there. All right, Cam, go ahead. I think you can
Thank you.
unmute yourself. Yeah.
Okay, just a quick question on that. So, because we definitely fall in that category that we don't have them here all the time. So, but we can put their information in. Then following the SACA like check boxes where it's asking for general surgery, call schedules, orthopedic, and anesthesia. Would I submit those because we don't have, we don't have trauma surgery, that kind of thing. So would I still need to submit the schedules for those three entities?
Is the expectation that they're coming to your trauma alerts?
No,
No. And are they covered 24/7?
no.
No. You do not need to submit the schedules.
Okay, even if I put them as a liaison, they're
If they're coming, because the schedules are really just proving that they have coverage 24/7. If you're
okay.
requiring them not to be there, then don't submit them.
Okay, very good. Thank you.
Okay. Great question. Thank you. I appreciate the questions. Respiratory therapy, optional. If you have it for a level 4, fantastic. Required for a level 3. Otherwise, I did just get a question about radiology, what this means in this medical imaging section down here. So this really is just literally everything about radiology. What services do you have? When are they available? Are they responding from out of house? Who is watching that response time? Who do you go to, your radiology liaison, when the CT tech is not getting there at an appropriate amount of time? So list that person there. That's a PI issue. What have you done about it? And you need your radiology liaison to come to your trauma committee to discuss response times and how are you going to track them better. That's a PI issue. So you need to have the radiology liaison, your go-to person there. And then this is essentially just asking how your processes work. Do you have X-ray respond to your trauma alert? Do you have your CT in-house 24/7? We do ultrasound in-house. How are these images read? Who does it? Who's your company that you use for? Do you have an in-house read on during the day? Is it all external? And then when there's a critical finding, how is that information relayed to the provider? Describe that all here too. And what's your process when there has been a missed injury? You've sent them home because they were okay going home, and then the overread of the diagnostic has a different diagnosis. So how is that process explained is a great way, is where we want that information to be relayed in that box right here. Okay. Man, this is probably going to get too lengthy. So I'm going to try to speed up here just a little bit. This is the picture of the level 3, same page, but the level 3 SACA, you can see the differences right away. It asks about neurosurgery services. Neurosurgery is not required for level 3 facilities. However, if you do have them, 24/7 coverage, submit their schedule, have a liaison that comes to your trauma committee. Between the alternative liaison and the neurosurgery liaison, this better be 50% here. So we'll let you have an alternative, but between the two of them, somebody's got to make it to 50% of your meetings or more. So if you have 4 trauma committee meetings in your 12-month review period, really will add these up. That's not a crazy goal to have the two of them make it to half of the 4 in the 12-month review period. But again, the idea is that you have a go-to person when your issues arrive about your neurosurgery patient or your ortho patient. Anesthesia, perhaps there was a delayed response. So really understanding that those liaisons are your go-to people and they should be coming to your trauma committee. And if you're a level 3, it's required that they're coming to your trauma committee. Same with your ICU coverage. ICU for level 3s have a few more criteria listed in there. So they say a surgeon on your criteria checklist required for level 3s. A surgeon must serve as a co-director or director of the ICU, must be actively involved in and responsible for setting policies and administrative decisions related to trauma ICU patients. That's criteria 1153. 1154 says the ICU director or co-director must be a surgeon who is currently board certified or board eligible. And 1156 says the physician coverage of the ICU must be available within 30 minutes and a formal plan in place for an emergency response. So we know that many things can happen in 30 minutes. And if your physician coverage is not in-house in the ICU, what's your policy for getting emergency? Does your physician come up from the emergency department? Is there actually somebody that's covering ICU in-house? So describing your ICU coverage in your ICU box here as well. And we're going to ask what the board certification is for your ICU medical director and your co-director. Your co-director, if your medical director is not a surgeon, your co-director has to be, is essentially what that's saying. Your ICU liaison and your liaison alternative, again, between the two of them, they need to make it to multidisciplinary trauma committee, which makes sense, right? You're in ICU, if you're admitting your trauma patients to ICU at your facility, you need to be able to follow the care of the patient all the way through their stay at the hospital. That includes the ICU. So if there's issues that arise, you need to be able to have your point person and get up and discuss it at multidisciplinary trauma committee. Already kind of hammered on radiology, laboratory services. This is just explaining what you have for blood products and what your lab coverage is. If you have in-house 24/7, if your response time for your out-of-house responders, how that's tracked, who watches that, how you get blood out of the blood bank at 2 a.m. on a Sunday if you don't have any lab personnel there. And if you have rehabilitation and social services, please explain that. The trauma registry section here. So I did snap that picture out of that. And this is the highlighted yellow is what's on the level 3 SACA and not on the level 4. I just want to highlight up here where it says submitted annually to the National Trauma Data Bank. If you're level 3, that needs to happen. And it's an annual call to the NTDB. And how do I have proof for that? Is usually just an email from the TPM saying, here's the email from the NTDB, or here's the receipt that we paid for it. I think it's still like $500 a year for the level 3 trauma care facilities. Some sort of documentation that you are participating in NTDB as a level 3. Benchmarking could be checked yes for everybody, level 3 or level 4, because Dr. Foss is now sending out our CQuick reports, and that is benchmarking. That's benchmarking against your other level 4s, against your other level 3s, against the state. If you have not seen your CQuick reports, please reach out to Dr. Nicholas Foss and he can get those to you. The question about how your trauma program utilizes the trauma registry to support PIPs. This can literally be anything that's performance improvement in your trauma program. So kind of on a small scale, you can run a report and Dr. Foss can help you get what you want to get out of image trend. Run a report that shows missing documentation for whatever it is, GCS before discharge, initial GCS. I can't get people to do a temperature on a CPR in progress because they're already dead. Well, that's still required to get that in. So how can I apply that to a performance improvement? And how can I apply that to my registry? I run the report. I see all my data missingness. Data missingness is a PI issue because we want to see those data gaps, and that's promoting good, clean data, and that's a PI issue. On a larger scale, how do I use my registry? Just kind of what we talked about. How about those ICU patients with multiple rib fractures that are getting admitted to your place? And I keep seeing pneumonia popping up as a complication on a report that I generated from my registry. So now I can see this complication. I can run this report. I can present my findings to trauma committee. We talk about it with our ICU liaison. We talk about it with all the hospitalists or the intensivists, the people that should be at trauma committee. And then we discuss some interventions that we need to be in place so we can minimize or reduce the chance of these pneumonias that are happening. So we've implemented this policy. And then I run this report again in 6 months, and lo and behold, our pneumonias as a complication to our rib fractures have gone down. And now I report that back to the committee, and I decide that I'm going to run this report every 3 months. So I'm keeping a handle on these pneumonias that are associated with our elderly or whatever rib fracture patients. That is PI in a nutshell. That is a perfect example of loop closure, and that you're continuously monitoring, that you're watching issues in your trauma program. The other one is just transferred to a level 1 or 2. I already touched on this. On the level 4 SACA, it just says higher level trauma center. And we're going to come back to the numbers here. I am wanting to be respectful of your time here. Let's see, what were the big parts that I wanted to say here on this form? This is the same for your level 3s and level 4s. And it may sound like you're repeating yourself through these questions very quickly. Review process for your hospital. This is essentially your PIPS policy in a nutshell described here. How you are finding your issues, first of all, how you're validating them, review your levels, your conclusions, your loop closure. Again, essentially your PIPS policy summed up in that box. The pre-hospital box, this is how you incorporate EMS liaisons or your medical director for local EMS agencies, how they're incorporated into the multidisciplinary trauma committee, how their charts were reviewed, how QI and PI happens with EMS partners. The transfer process to other facilities. And again, it's going to be that we know that you're already reviewing these, but you want to talk about here how you've received follow-up, what you did with that follow-up, if you had a new policy that you had to implement, if you got that follow-up back to trauma committee, and then morbidity and mortality. Essentially, this is going to be what you had said on the first box. However, there may be something different that you guys do for morbidity and mortality. Perhaps you get an external peer review that's required if somebody dies at your place. You would want to mention that here. Perhaps there's an autopsy that comes into play for your mortalities, and we get the autopsy as per our policy. We take those findings back to peer review. This section here is again the same. So, preparedness is self-explanatory. This talks about transfer to definitive care again, and that probably sounds like it's repetitive, but really it's how the actual transfer process goes in this step. It's not just that you review transfer patients. How are the centers contracted? How do you apply your transfer guidelines? Who's communicating with who? And even your transport, how it's arranged and how barriers are identified is more what we're after on that question there. Documenting occurrence of resolution and loop closure, what happens when the issues are identified and how the document is complete. Loop closure is not easy. It is always the hardest part to prove and to identify. Loop closure is just not getting that feedback from the receiving facility either. Loop closure really is what changes did you make, what policies did you implement, and what was the outcome? And if that outcome really prevented that issue from happening again. We implemented something that made a huge difference or it didn't, and we decided to take a different route, but I continued to track it. And over the course of the next 3 months, 6 months, or 12 months, I went back and I tracked it, and we decided that it did make a difference. So we decided to close the loop on that particular PI issue. And wanting to explain that in this box is what we're after there. And if you need to apply an example to it to make it clear, by all means, please do, because that will help us, especially on the paper reviews. You cannot write enough in this box on the paper reviews. At the visits, in person or virtual, you get a chance to explain that. But on paper reviews, really make sure that this is clear on how you get loop closure. And then cares for pediatric patients down at the bottom. This is a great place to talk about things that you've done as far as equipment that you have. If you have PECs, pediatric emergency care coordinators, if you are an IPEC hospital, be sure to put that all down in here in your pediatric section. The last page is the same for level 3s and level 4s, really self-explanatory. The kicker here is that you may have not have been the TPM at the last verification. Track down those old reports from your previous verification, look at the criterias, how the criteria deficiencies, how they were resolved, and make sure that they are resolved, and then how you address the recommendations as well. And I can certainly get you your final report from last time if you can't track it down. This last page is just really anything, absolutely anything else you want me to know, or the survey team that you want to know about your upcoming verification. Okay, so here's your laundry list of, this is all your supporting documents, and this is the list for the level 3. So this is different on the SACA than your level 4s. These are all your supporting documents. Please, this is the stuff that is organized. Here's the picture of your level 4 laundry list. Anytime that you can provide de-identified examples, for instance, on this one where it says completed samples of OPPEs, of the APPs and the ED by the TMD. Provide those examples. You don't even have to de-identify them if you don't want to, but we'd like to see filled out forms. Blank forms really kind of only get us so far, but we'd like to see filled out forms. Remember, myself, the state, the surveyors that we contract with are all held to confidentiality agreements and HIPAA. So really this information is protected. So, and you may have a filled out OPPE that was on a provider that was one of your PI issues that you needed to do some targeted education with the care of the trauma patient. And there's where you sign and date at the end. Make sure that you're reading the tips here for your SACA submission. Make sure you're familiar with the Orange Book and your criteria. Again, this will say level 4 for your level 4, and your criteria checklist that, again, I send with that 6-month notification. Fill out your application completely and in detail. Remaining organized throughout the 3-year verification. And I know that's hard with the turnover of the trauma program manager. You get thrown into it, you get little to zero training. I understand that completely. So trying to stay organized is really key. It's going to just make your second verification so much easier. Using PDF files, reducing the file size. We already talked about that for easier email submissions, and just making sure they're labeled as clearly as possible. Ensure your policies and guidelines are up to date. Don't send old policies, especially if you are a paper review, because again, in that 4-month period from the time you've turned in your SACA to the time the visit happens, I understand the policies get approved as on a continuous basis, but make sure that you are sending the most up to date. And I don't have any problem with people borrowing policies. I encourage it, job descriptions, so on and so forth, but please make sure that you have customized it to your facility. It just looks kind of shady when I'm seeing somebody else's job description and they report to Department of Health in California because it was somewhere that you found online. I don't have any problem with those policies being used. Make sure that it's applicable, what is actually happening in your site, and is customized to your place. We see that a lot. So just go over your policies to make sure that they are up to date and that there are no miscues in the policies that reflect that it's somebody else's, that it's actually, you have looked at it, you've applied it to your place, and you've customized it. Okay, I am running out of time. Again, this is recorded if you have to leave, but I am going to talk specifically about this section in the SACA now and how you get these numbers. Again, the very first thing that the surveyors and myself, not the very first, one of the things that we do is get your trauma services summary report from that review period that we identified early on. And we want to compare these numbers that you've manually put into your PDF and submitted. And again, that 12-month period should match. Pretty self-explanatory, the majority of these, but there are a few kind of confusing ones on here. So I'm going to do my best to clear that up for you now. Number of ED visits. This is super easy to find. Your ED managers, your hospitals, directors, administration, everybody knows how many ED patients you saw in that review period. So make sure that you get that accurate number. The next line item is the number of patients that have met registry inclusion criteria. Okay, I get down to my other things here too, so I make sure that I don't forget anything. Okay, the number of patients that have met your registry inclusion criteria. This, I'm showing you an example on your trauma services summary report now on this next page, and just pay attention to the red circle. This is out of your sub-report 1. The number of patients that have made registry inclusion criteria are the total number of patients in your registry for that review period. Now, how do that's period. That's just the number. It's just that plain. The question becomes is, did I appropriately put these patients into the registry? Well, how do I know if I've appropriately put the correct patients into the registry? This is assuming that you have followed the inclusion criteria from the data dictionary. Go back. Now, the data dictionary, that tells you exactly how to put the patients into the registry. It goes through each data point in patient registry. If you don't know what the data dictionary is, never heard of it, you're probably not putting the patients correctly in. Here is where the confusing part happens. The state has, for your state verified trauma centers, a state data dictionary. That is also written into administrative rule, and it references the 2017 data dictionary. In the meantime, ImageTrend, being a separate corporation, utilizes the NTDB data dictionary. The NTDB updates every year. ImageTrend gets a hold of that, and they map their program, the ImageTrend Patient Trauma Patient Registry, to the NTDB. Okay, so you can already see that there's going to be gaps, right? For one, in the law, the way that it's written, we cannot keep getting updated data dictionaries on the state data dictionary. The state data dictionary is based off of NTDB, but you will see the differences. You're like, okay, the data dictionary says this. That's not what I'm seeing on the ImageTrend when I'm trying to put the patients in. The reason for that is that ImageTrend is actually, all of you will probably laugh a little bit, more up to date and current on their mapping on what you're seeing as you're going in to input your patients. Hopefully that makes sense, but it really is kind of a confusing thing to get a hold of. Now, throwing one more caveat in there. What is going to help here, hopefully, April 1st. The other thing anticipated to come with our administrative rules is our new 2025 State Data Dictionary. This is going to be so much more reflective of what you're seeing on ImageTrend. And Nick, Dr. Foss did a really great job of clarifying that language, making it easier to understand how I get the patients in. Why am I telling you all of this? Because that directly reflects who met your inclusion criteria, right? Because that's our guide, our data dictionary, on who goes into the registry in the first place. If you don't know what the data dictionary is, you need to get your hands on that. And I get it. Again, you get thrown into this to say, oh, you're the trauma coordinator, you're the trauma program manager. Make sure that you get the patients in the registry. This is how you do it. You click a bunch of buttons, put in a diagnosis, and if it's a trauma alert, put them in. If it's not, don't put them in. If it's this, don't put them in. If it is, do put it in. And I know that there's a lot of gaps in how education goes between who is putting in what, between registrars, between turnover, and you're like, man, I just don't get this. Please reach out, and Dr. Foss, we can go through what this means, what the data dictionary means. It is a very self-explanatory document. We anticipate the new revised, more reflective of what you're seeing on image trend to come in April. So now there's not crazy earth-shattering things happening between the data dictionaries as well. But it does clarify some language to make it more user-friendly. Again, Dr. Foss spent a lot of time on that data dictionary. He knows it inside and out, and it is your tool to find out who goes into the registry. And again, that's going to be your total number of patients found on your sub-report 1. This is where I'm looking, sub-report. Your trauma services summary report are a bunch of these sub-reports put together. So sub-report 1 has just your total number of patients. You'll see through every report that that this total will always end up to be your total. So it should always total the same amount through each sub-report. Nick, thank you. Dr. Foss, I just realized, even though it's going to be released in April, we decided to push it back till May before utilization. So thank you for the point of clarification. You guys can see that in the chat. We just want to make sure it's all lined up correctly with NTDB, the NTDS for the 2025 data dictionary. So it will probably be officially utilized by all of you in May of this year. Okay, so that answers this line item here. The patients that met trauma registry inclusion. I'm going to skip over this one and this one. Okay, and let's cover these really easy ones. Number of patients that went to the OR from the ED, really self-explanatory. That's in the sub-reports as well. Admitted to your facility. Admitted for the purposes of this means even beyond the emergency department. So if they stayed in the ER physically but were admitted to OBS for 23 hours observation, that's an admitted patient when we're talking about filling out numbers on the SACA. And that's also included in your sub-report on your trauma services summary report. Patients transferred to level 1, level 2, or if you're a level 3, if you're a level 4 and you transferred to a level 3, that's very self-explanatory. The number of patient deaths that occurred, that's right in those sub-reports too. You'll see, in fact, I think it's even on that example I just showed you. And then trauma referrals to Region Organ Procurement Organization, your OPO, or your organ donors. I think pretty much everyone has gotten a hold of those reports from IDN or the Iowa Donor Network. There are some beautifully graphed reports that they can send your facility for a specific time range. Get a hold of those from IDN. And they also give a great analysis of so many of your trauma patients were tissue donors. So many of your trauma patients were solid organ donors. So that's a great summary. Reach out to Iowa Donor Network if you don't have a hold of those. But those, I haven't seen a facility recently that hasn't submitted those. So I think everybody's got a handle on that. Okay, the complicated question. Stay with me as much as you can here about MET trauma alert activation criteria. Subreport 7 says trauma team activation level. So I have all of these numbers highlighted in yellow. And the reason that I have that is because you need to look at the ones that were called a trauma alert. In this particular case, level 1 just means they have one level of trauma activation here. If you have a multi-level trauma alert policy, it'll be a level 1, level 2, and not activated are the patients that were not called trauma alerts. Why do I need to look at all of this? Okay, patients that met your activation criteria based on your trauma alert policy. Your trauma alert policy. So this is where your manual work comes into, and this is also why Image Trend can't just spit out a perfect report to you, because Every hospital on this call and throughout the state has their own trauma alert policy. So if I'm truly looking to see what met, remember what our question says here, what met alert and activation criteria, that is very site specific. That is very site specific to your trauma alert or activation criteria. So I do need to look at all 447 or 474 of these patients. Why do I need to look at that? So I need to look at the ones that were not activated first, my 198 that should have been called. Were these ones that were sick enough, admitted enough, dead enough to make it into the trauma registry, but yet we missed it on the front door because we missed it as an activation? That is essentially an under triage tool that you need to look at. I also need to look at the 276 that were called as trauma alerts. Why do I need to look at those? Did they each one meet the trauma alert criteria that I have at my hospital, your specific alert criteria? And that is essentially kind of what is your over triage, because they were called, but they didn't meet my alert criteria in my hospital. Then you're looking at the ones that weren't called and should have been called, and the ones that were called but didn't meet your criteria. And that is the number that needs to be filled into that line item on your SACA. Because we are talking about the ones that truly met your alert criteria here. So there's not just a number that can be spit out from subreport 7 on that. Does that make sense? It's very, very confusing. It's kind of abstract. It's hard to get a handle on for this particular question, but you want to answer this specifically. The number of patients that met trauma alert activation criteria for my facility. Again, I need to make sure that all 474 did and were supposed to, or didn't and were supposed to. Questions on that piece? Again, and I'm sorry, I'm going way over, but this is really hard to kind of grasp. Craig, go ahead, Craig.
I always have a question for you, Sarah.
I appreciate you.
Hey, so I just need like a clarification of all that. Like, is there a table that can be made that says enter this number and then enter this number, kind of like when we are calculating over and under triage? I use a chart that I enter the numbers and it kind of calculates it out to kind of simplify that. Or can you email like add this plus this? Or
and that is a great question. What I see throughout the site is that, and I don't have a good answer for you, Craig. What I see is on your documentation, and I don't know what your Epic Trauma Narrator says, but a lot of people that are still using their paper documentation or figuring out a way to capture this are putting it right on that entry point paperwork that says, is this a trauma alert? Yes or no? What level, if you have multiple levels of trauma alert, was it appropriately called? Does it meet activation criteria? And between those three questions, now you've got your number already answered. And I think Dr. Foss is on still too, and he may have a better insight without, completely going into over under triage, resource utilization, on and on. This is just the raw count that we're looking at for the SACA. How many of your patients that came through your door met your activation criteria is the number that we're looking for there. It doesn't necessarily mean that what we're seeing here in the yellow can answer that. And I know that that's really confusing, and I apologize for that. But if you try to think about it abstractly about not activated, were they not activated because they didn't meet alert criteria, or were they not activated by mistake? And they did.
I'm sorry. So basically I need to kind of calculate the ones that were called plus the ones that are
Yes,
missed.
yes.
Thank you.
Now, don't forget, the ones that were called, though, may have been called mistakenly, too. And that's your over triage. Because they didn't meet alert criteria, but yet they were called. And you need to look at those manually as well. So there's a little manual work here, but try to keep thinking about what you're actually looking at in the numbers and what the question is asking on the SACA. That is what met your activation and alert criteria. I don't even think I want to talk about putting ISS in. I think I'm going to leave that there. I had a few other things to say, but I think I'm just confusing you. I don't want to confuse you more because it is kind of a hard concept to grasp. Let me go back to the SACA here. So I think I've beat that dead horse. Trauma alert activation criteria. And then the number of alerts and activations is real easy because that's here in your green from your same sub-report. We know how many were called, but you can kind of start to sense what we're trying to look at when we ask these SACA questions based off of your numbers in your registry. We want to see how many were called inappropriately, whether it was over or under triage, and based off of your activations. But we really want to see that you're looking at these numbers and that they make sense to you. And then number of patients with an ISS of greater 15 is really easy to get in your sub-report number 8, or not 8, sorry, it's on the next page. And if I can find my cursor, in the pink here, in sub-report 12. Okay. I'm going to comment here just on ISS scores and on your blue highlight, because this takes it to the next step as far as what PI goes to and helps you start thinking about this. Adding your ISS score to your reports kind of give you a handle to what to look at first, right? Because you're looking at the really sick ones that are in your registry. Your ISS score cannot possibly match your trauma activation criteria at all. So remember that. ISS is a retrospective look. Everybody knows the diagnosis after the fact. Nobody knows the diagnosis when they're coming in the front door. And their front door equals your trauma alert criteria. So you have to look at it at face value. Does it meet my trauma alert criteria? But if you throw an ISS score in there, that's going to help you understand possibly why it was under triaged. So when we're looking just straight at numbers, in this particular example, we've got sub-report 8 in the blue. I might have an issue with over triage here because I've got 276 patients that were called trauma alerts. 176 plus 19 went home of that 276. So are we calling these too much? Is there a component in my trauma alert policy that captures these extra patients, assuming that everybody's calling it correctly and following the criteria? Is there a component in there that's leading us to overcall, over triage these patients? Because most of them are going home. And that's what performance improvement is. Because now you're thinking and studying these numbers and you're looking at them going, okay, I need to take a look at this trauma alert policy here because we're capturing these non-sick patients. We are utilizing resources on an activation that is getting utilized too much. That's thinking and studying about your numbers. another picture that you can paint when you're thinking and studying, 398 of those 474 had an ISS retrospectively, again, looking of 398. Again, just kind of painting the picture, studying what these numbers actually mean, drilling down to each of these cases, understanding what happened. Were they appropriately called? Were they not appropriately called? Is hindsight 2020? Absolutely. But that can help you adjust your own trauma alert criteria to what fits your patient population. And I went way over, and I really apologize for that. But what I will say is when you're studying this report, thinking and studying is your performance improvement. And I heard this a long time ago at a TQIP convention when they said, you know, if you go in there with your door closed and you're just sitting there staring at the numbers and asking why and studying these numbers, you're working. That's still work. That's still a performance improvement because you are essentially thinking about what I'm getting out of my registry. And that really is what we want you to utilize the registry for, is your performance improvement. Okay. Questions on that? I hope this was a little bit helpful. If you need a one-on-one tech assist with me and Dr. Foss and or together, please reach out to us. Dr. Foss is really good about having that fancy little scheduling under his signature name, and then he sends that on to me, and I jump on when I can if I don't have another verification going on to help out. And between the two of us, I feel like it's beneficial to kind of answer some questions. At least that's the feedback we've gotten from you guys. Questions right now, open forum, confusing, helpful. Did you know that you had to do this work on the SACA? Questions about any of the supporting documents, questions about how to submit.
Sarah, I do have one more question.
You bet, Cam, go ahead.
When we were looking at the organ donors, it says
Mhm.
number of trauma patient organ donors.
Yes.
You are asking there for any trauma patients that donated their organs, not
Yes.
that they're registered organ donors.
Correct.
Correct. Okay.
And if you can, yeah, and if you
Sure
can
is.
get that out of IDN, because I remember trying to track that down myself, it was really, really hard because they don't tell you who the patients are, right? So it's really hard if you have a huge amount. A lot of times you'll get that feedback from IDN that says, thank you, Cam, for participating. Recent 54-year-old male that came through your facility was able to donate 2 lungs, a liver, and his heart. And you're going to know who that is, right? You're going to know that particular person, based off of that information, you can put that number there, that there were 4 organs donated from that one patient. But that was a trauma patient that came in. You guys got got him transferred. They got the organs harvested. And that just strikes me. Maybe you guys don't get that information.
No, and that's what some of it is hard. Like, I don't have any deaths to report in my reporting time period, but that doesn't go on to say that they, may have
Right. And you
deceased
will
later.
never get that
No, nope.
from the receiving facilities.
Right.
You could put NA there or unknown, and I would
Okay.
accept that as an answer.
Okay. Thank you.
That will be
That is
something
that's exactly what I have written on it. So I just want to
Yeah,
be sure I was thinking
perfect.
correctly.
Because that will be something to be looking at. So when the gray book does come and we get our level 4 standards too, the SAC is going to look completely different. I did decide to do this presentation today because it's going to be recorded, and all of our level 4s, all 101 of them, are still on the orange book until the foreseeable future. The level threes, once the gray book comes in, we will be overhauling the SACA to reflect those 2022 standards. So the SACA and the criteria checklist will look different. More to come, but that is certainly one that needs to be adjusted for level fours, because you're not actually harvesting at your level 4 facility where you would get that. Thank you very much, Cam, from the IDN for your referral from Iowa Donor Network. The receiving hospital that you sent that patient to is getting that letter, not you.
Right.
Other questions? Did you want? Wow, my meeting ended. Did the recording ended? Sorry, recording. I hope the recording didn't end. But again, you can reach out to me and Dr. Foss, and we will help you. No other questions, and I'll let you go. Thanks for staying late. I appreciate all of you and all of the work that you're doing. Have a good weekend, everyone. And if you're working, I'm working as well. Stay warm tomorrow, the one cold day. So, all right, take care.